Hi there. Thank you for joining me once again on the program Your Doctor and COVID. I'm Dr. Mahendra Carpen, Head of Medical Services and Cardiology at the Georgetown Public Hospital Corporation. We continue our conversations around the COVID-19 pandemic. Remember, if you have any questions or comments, please feel free to send them by WhatsApp to 620-6275 or send an email to docandcovid@gmail.com. Today we continue our conversation with experienced media operative Mr. Kit Nascimento, who yesterday started to ask about Guyana's situation as regards the COVID-19 pandemic. So once again, we'd like to welcome Mr. Nascimento, and for the rest of this conversation, we will take our masks off because we are more than 7 feet apart from each other, and it will then be considered safe for us to take our masks off. So Mr. Nascimento, yesterday when we were speaking, you wanted to ask a particular question about Guyana as it relates to the COVID-19.
Yes, I did ask you. I said, how well are we doing? And I suppose I would pose that question in terms of how well are we doing comparatively, first of all, perhaps within our own region, and then internationally.
So we are right in the middle in terms of how well the country is doing compared to the regional neighbors as well as our international compatriots. In the world of assessing how well we're doing, there's something called a case fatality rate. Case fatality essentially is the percentage of deaths versus the number of positives. The WHO has recognized that across the world, regardless of how rich you are, how poor you are, what type of treatment you administer, what kind of ICU admission criteria you have, the case fatality rate is about 2 to 3%. That is across continents. As we speak today, this is the 3rd week of December, Guyana's case fatality rate is 2.59. We would have just crossed over a total of 6,170 positive cases, and we have 160 deaths. Now, mind you, every death is regrettable. One death in any scenario is too many. But we have to face reality that sick people are most vulnerable, and this is not unique to Guyana. This is across the region, this is across the world. We are no better, we are no worse. We are on average keeping up with what is happening across the region and across the world. And I must say with some pride that in terms of treatment that is available, Guyana has been somewhat in the forefront in utilizing novel therapies and new treatments. I believe the one thing that we still would like to have that we don't have is the immunoglobulins that were used, but even that was used in an experimental basis on VIPs such as President Trump in the US. So we're not behind our neighbors in CARICOM or the Caribbean. In fact, we're right up there among the leaders in terms of what we offer for treatment in our COVID-19 patients.
And we do actually have special problems. We have very wide open borders with Brazil.
Yeah, that's a very big concern. Our borders are not, as easily managed as island states. And there are lots of landmass that are porous that people can cross in and out. And even when you know that they're crossing in and out, it's difficult to actually keep track of people once they get in to our borders. And then the testing initially had been quite a challenge. So we were not yet able to say with certainty in a quick turnover time if persons are positive or negative.
Well, our indigenous population live on the borders.
Yeah.
And they have been habitually used to crossing the borders as though they don't even exist.
Exactly.
And it is very hard for them to grasp and understand that every time they get into Brazil, they're exposing themselves to a country which is far more dangerously threatened than we are in Guyana. But then they bring it back with them, and you don't know if they brought it back with them.
Right. So we have seen around the world that population density is an extremely important factor for the spread of this disease. It can get really out of hand in more densely populated areas. We see that example in New York, in big cities, versus populations that are more sparsely situated around countries. And Brazil, as you know, the border regions in Manaus, etc., those are very densely populated areas. So it's easier for infection to spread among people there, and then easily to be transported across the border back to Guyana.
And then they will come to town. They'll
Right.
get on a minibus, and they will come to town, and then it spreads even further.
In the early stages, we did have patients who had rapid testing, for example, done in Lethem. It was negative, but they had the symptoms, and then came through the Ogle airport on an aircraft with lots of other passengers, and through the airport with the pilot, etc., and ended up in the Georgetown Hospital. And then when the PCR test was done, it was positive. And then we had to do the complete backtracking and contact tracing, etc., to try and isolate and quarantine the relevant persons.
Now, of course, our airports, including Ogle, are very strictly managed,
Yes,
and very successfully so far.
yes. That we're very pleased about. We have come a long way in this pandemic.
I wanted to ask you this, talking about how well we're doing. Recent results seem to be showing that the number of positive tests, and indeed the number of deaths over the last month or two, have decreased quite dramatically.
That's an astute observation. I have not really been a fan of positive as a metric to measure how well or how badly you're doing. Because if you go to a village, for example, that this disease is rampant, you will find out of 100 tests, you may get 70 positive. Versus if you go to another area, you might do 100 tests and you get 20 positive. It just means that the concentration of positive cases are different from area to area. My assessment of severity or how well we're doing is the number of ICU admissions. And that's perhaps because I'm a little biased working in a tertiary advanced hospital at Georgetown. But that metric for me is more useful. And indeed, you are correct. We have seen a drop in the number of ICU admissions, the number of ventilated patients, the number of persons with severe symptoms awaiting results. And thankfully, there is a downslope in the death curve. Now that is December. Remember what you and I are seeing in the city and elsewhere as we move around. We will, I believe, see a spike in cases and sick admissions sometime in February to March of 2021.
This is because of Christmas?
I believe it might be a couple of factors. People, let's be real, people are fatigued with the restrictions and the discipline required to maintain social distancing, wearing masks. It's the holiday season. People are shopping. People are going to families. They're visiting elderly, sick relatives. Children are coming in, whether it's from Georgetown back to the countryside, etc. More people are going to be exposed. And, that combined with some maybe imported cases that may or may not be missed at airports or coming onto flights, we do anticipate that there is going to be some surge in March, February or March. The last first surge, we were a couple months behind the US in terms of their first surge. And there's no reason to believe that we will not follow the same pattern of being a little bit behind the US surge. US is having another surge right now, and it's pretty bad. In fact, in the largest populous state in the US, in California, they're starting to contemplate what we call rationed care. So if 5 persons are ill and they have 4 ICU beds, they will determine which 4, and some of the criteria used will make people uncomfortable with, what that implies.
Yes, indeed. In fact, in the United Kingdom is also in significant difficulty, and I have a grandson in Switzerland. 4 months ago, they were almost ignoring COVID in their general behavior.
Yes.
They were out together, traveling quite freely, not wearing their masks particularly. Now, all of a sudden, Switzerland is seriously threatened.
Yes.
Part of that is probably because of the winter, and people are driven indoors in cold climates and tend to get together more closely. We fortunately don't have that problem here. So you're not sure that you can put your finger on why this drop in positives and indeed in deaths.
Yeah, well, this pandemic, as we've seen around the world, it follows something called a sigmoid curve. It may sound a bit callous to say, but what happened is in the early stages, it just took the sickest person, so it took the cream off of the top. So once those persons would have died, then there will be a decrease in deaths until the virus then starts to infect another critical mass of persons, and then more sick persons reach to that stage of health where they are now most vulnerable. So we have seen a drop because the sickest have already died.
In simple terms, there are less people in the population that are likely to be killed by the disease.
That's correct.
So we're losing our more vulnerable people first.
Correct, just like the rest of the world.
So there are less vulnerable people, less old people,
right?
Therefore less positives.
Right.
But that will change again.
I believe so. If we're to just follow the epidemiological pattern of the disease, of what's happening around the world, there's no reason to think that we are different. We always believe God is Guyanese, and I believe that. But sometimes we have to face the reality and follow the science.
Now, I wanted to change the subject completely. We are constantly reading about various medications that are miracle cures. But there's 1 or 2 prophylactics that seem to be having quite extraordinary effect in the way they not cure, but reduce or slow up the disease if you're taking them. One of them I've read about a lot. In fact, I actually bought a package with me called Ivamectin. I don't know if the camera can see it. It's a little package of Ivamectin. This is a drug that is used for filaria.
Yes.
In Guyana. And it's readily available in Guyana. And it's not expensive.
Correct.
What do you know about this, Doc?
So I do know that there are several claims about several agents that can be helpful. And Ivermectin is one such. We can discuss many of those, not just ivermectin, but several others. And we can start by what we know our practice has been. We usually follow the lead of more advanced guideline creating societies like the US and the European societies. And so far, while they have no specific objections to the use of these medications, they do not yet have recommendations for absolute use. So we are a little bit hesitant to then be jumping to the front on this because we simply do not have the tradition to be the leader in these kinds of scenarios. So we would await further scientific research and outcomes before we can universally and unequivocally endorse these products. But we can continue that conversation in more details tomorrow. Remember, we're talking on the program Your Doctor in COVID. I'm Dr. Mahendra Carpen. If you have any questions or comments, please feel free to send us a WhatsApp message to 620-6275, or you can send an email to docandcovid@gmail.com. Thank you very much for listening and for watching today.